Welcome to Essentials of Clinical Supervision. My name is Dr. Tara Jungerson, and I'm an assistant professor here in the Mental Health Counseling Program at Nova Southeastern University. Today, in this 2-hour webinar, we are going to be talking about some of the following objectives. Today, it is my intention that attendees will leave the session with a clear understanding of clinical supervision, that hopefully you will be able to identify key characteristics of the roles and responsibilities of both supervisees and supervisors. And also we're going to review Bernard's discrimination model as one of the main theories of clinical supervision. And along those lines, we are going to discuss the protocols and practical strategies in supervision across these roles and foci in Bernard's model. Finally, we're going to talk about the process of credentialing of supervisors both in the state of Florida and nationally. So these are the order in which we're going to be covering, starting off first with definitions of clinical supervision. Before we get to that, I want to talk a little bit about my background and interest in clinical supervision. I became interested in the research more fully once I got into my doctoral program. After having worked in the field for about 10 years in between my master's and my PhD, I found that there was a very wide variety of supervision models and techniques being used, and definitely a wide variety of supervisors and types of supervisors. I remember the support I received from my first individual supervisor in my first practicum, along with facing my initial fears of being in front of a client for the first time, or the invaluable learning experiences I had in group supervision with multidisciplinary team members. I also remember being challenged as I developed my own identity and style. So looking at my dissertation research about clinical supervision, I noticed that it was different based on the location of where it was being conducted, the context of the supervision, the types of clients served in the different sites and agencies, but also varied due to the clinical orientation of the supervisor. So I wanted to further explore how to translate the supervision research into more practical strategies for this important training component. So each of you that are watching this webinar have either experienced clinical supervision in the past, perhaps you're currently providing clinical supervision, whether it could be in the schools, it could be community mental health, it could be college campuses, inpatient settings, residential settings, and others. I want to ask you to kind of think back to what your own supervision experience was like. What were the best and worst parts of it? What was something that you would have liked more of in supervision, or maybe less of in supervision? Also think back to what were the relationship dynamics like between you and your supervisor or multiple supervisors. So hopefully your answers to these questions and your thoughts about these questions will help ground us somewhat in the content in which we are about to explore. So to start off and talk about some of the definitions of supervision, I'm going to move past the Webster's Dictionary definition of supervision, which is to oversee, and talk about the definitions of clinical supervision. It is an ongoing educational process, and the key word there being educational, where the supervisor aids the supervisee in acquiring appropriate professional behavior through an examination of the supervisee's professional activities. Another definition that we could consider with clinical supervision is that it is an intervention provided by a more senior member of the profession to a more junior member of the same profession. And I think this second definition especially talks about the relationship dynamics that are inherent in the supervisory relationship, which we'll talk a little bit more about today throughout the presentation. Supervision is a relationship that is evaluative. In other words, there is going to be an evaluation at the completion of the supervision term. It extends over time, and it has the simultaneous purposes of enhancing the professional functioning of the junior member, monitoring the quality of the professional services offered to the junior member's clients, And I think that's key because the purpose of supervision is ultimately for the protection and welfare of the clients served. But also supervision serves as a gatekeeping process for those who are about to enter the profession. And the gatekeeping process occurs in different parts of the clinician's development. I also want to compare supervision to some other processes that are similar in practice or sometimes in nature. First, I want to compare supervision versus education. There are some similarities in that both involve teaching and learning. The supervisee is learning some of the key points of the profession, maybe learning clinical techniques and intervention, and the supervisor has this professional knowledge to pass on through this didactic process. Also, both have evaluative aspects. Both the supervisee and, for example, a student at the end of an educational process are going to be evaluated at the end of the term. And both are time limited. There is a start date and a stop date for supervision and also the educational term. But there are differences. With education, there is a uniform curriculum. There's the similar goals and objectives. However, with supervision, that will change based on the context and the supervisee's needs and the site. I also want to talk about the difference between supervision and consultation. Consultation the supervision can evolve into more of a consultation for more senior level professionals. And so this is a way for these senior level professionals to get ideas on how to handle a particularly difficult client or to regain needed objectivity. Typically with consultation, that is sought out freely. And that is one of the differences between clinical supervision and consultation. Consultation is freely sought, it's non-evaluative. Also, when you think about the practice of supervision versus the practice of consultation, it's a lot easier to disagree with a consultant versus your own supervisor, at least in face-to-face. Parties are also not necessarily from the same discipline when a consultation is completed. In fact, that's many times when a consultation is sought out, is when there is expertise needed outside of the normal professional functioning. So I think that one of the examples of consultation that if anyone's ever watched the TV show The Sopranos, when Dr. Jennifer Melfi sought out supervision, which was more of a consultation role for her in how to deal with her mafia-connected patient, Tony Soprano. And one of the key points I want to focus on is the difference between supervision and counseling and therapy, because this is something that comes up very frequently in supervision trainings and also within the supervisory relationship itself as to the amount of personal development that the supervisee is going to go through within that supervisory relationship. The similarities between supervision and counseling and therapy are that both of them involve helping someone, whether that be the client or the supervisee, examine aspects of their behavior, their thoughts, and their feelings. The therapeutic intervention with the supervisee, however, should only be in the service of helping the trainee to become more effective with his or her clients. So any sort of focus on any sort of the personal behaviors, thoughts, or affect is going to be only as it relates to the clinical service and the clients. The differences between counseling and supervision would be that a supervisee is typically not given a choice over who their supervisor is, and they're not given a choice about whether or not to receive supervision. And typically with a client seeking services, they can have that choice and they can decide when to stop. Also, there's going to be a different initial contract. And we'll talk about contracting later. However, therapy involves helping the person deal with personal issues, whereas again, supervision focuses on professional issues. And we need to keep that in mind within that context. Other similarities and differences with counseling and therapy. Both involve a power differential within the dynamics. But the differences are are that the evaluation piece. Because with evaluation of a supervisee, the results are very different and have a lot more significance and impact on the person than perhaps an evaluative or diagnostic workup of a client, unless we're talking about a court-mandated, court-adjudicated client. For example, if I have a poor evaluation of my supervisee, it may result in a delayed graduation, even prevent graduation if we're talking about interns. It may prevent licensure if this is postgraduate pre-licensure supervision. Whereas my negative appraisal of a client may not have any concrete life-changing consequences, again, unless we're talking about the court-mandated clients. Another thing to consider is that the time spent together between supervision and direct clinical work are going to be different. The supervisor typically has many more opportunities to observe the supervisee. There's different contexts for observations. They may be in staff meetings together. They may be having lunch together. There's a lot more opportunity to observe the supervisee, whereas a client, depending on the site or the context, a therapist may run into their client once a week. There is more self-disclosure typically by a supervisor in supervision than would occur in a counseling or therapy session. And we'll talk about the pros and cons of self-disclosure, but it's typically more of can adopt more of a mentoring process where sharing some personal examples of how a client situation might have been handled in the past would be an appropriate self-disclosure. And there are different boundaries between supervisor and supervisee than there are with client and therapist. And I put a question mark by this because this is one area that supervisors and some of the research differ, is are the boundaries exactly the same as it would be in a clinical relationship, or are they different? And I think you're going to hear different versions of this based on personal style, based on where the supervision is occurring, and sometimes based on both supervisee and supervisor characteristics. Now I'd like to move on to the roles and responsibilities of supervisees. I think before we get into the actual responsibilities of the supervisees, we need to look at some of the common expectations with which a supervisee will enter supervision. Some may not know what supervision looks like. They may assume that it's a very passive process where the supervisor more or less is the expert that bestows knowledge kind of from the top down to the supervisee. Others may have had experience with supervision and realize that it is that exchange between the two. But either way, there is typically some anxiety that is occurring especially with a very new intern or practicum student. There is this need for impression management because the perception by others can be a contributor to the anxiety that the supervisee is experiencing. And a lot of times they're dealing with this imposter syndrome where they question their competence, they question their abilities, and sometimes that providing them that support to fake it till you make it in some ways, and supporting those supervisees with lower levels of autonomy. In fact, we'll talk a little bit about Stoltenberg's IDM model, which is the integrated development model, which acknowledges that supervisees and trainees start and develop throughout their training process with different levels of cognitive complexity and different levels of motivation, different levels of autonomy, and definitely different levels of awareness and self-awareness. So the newer supervisees tend to be very rigid, tend to think in very black-white terms, are extremely anxious. And then throughout the process, throughout their experience, they tend to move towards increased autonomy, increased reliance on themselves, and begin to integrate different pieces of the client, their curriculum they've learned, professional ethics, and also multicultural variables and multicultural competence. Sometimes the supervisee moves towards higher levels of autonomy and maybe even less willing to take feedback from supervisors. However, most come with a willingness to learn, and it's been my experience that those that do have a sort of overdeveloped sense of competence usually get tempered by the clients, depending on the therapeutic outcome. So again, just to talk a little bit about specific needs and roles and responsibilities of intern supervisees or practicum student. We'll talk, this will be the pre-graduation experience. The interns are focused on combining educational praxis with the application and integration of the knowledge and skills. Again, this is getting at Bloom's taxonomy where they're actually applying the knowledge that they've learned. They're responsible for accumulating direct clinical contact hours, and that's going to vary based on the curriculum, based on state licensure requirements in the respective states, and it may differ by profession. There are also many indirect services at the site that the new prac student or the new intern is having to synthesize and incorporate. And this can kind of lead to the anxiety of just performance of the clinical skills and appropriate interventions. A new intern is going to be learning the referral sources and the referral process, both of intakes and discharges at their particular site. They may be attending staff meetings and trying to navigate the dynamics of the group composition at the site. They may be attending treatment team, learning different models. For example, maybe shadowing a psychiatrist, learning about medications, possibly shadowing an addictions counselor, running A&D groups. There are also definitely learning documentation. And while there are many documentation pieces that are common across all sites, the differing paperwork, the different lengths of the intake assessments, the treatment plans, the treatment plan revisions. These are all going to differ by site, and there's a little bit of a learning curve with that process. Also, keeping in mind, interns have what's called concurrent supervision. In other words, they have their site supervisor, who is their typical one they are staffing their cases with, who is responsible for the intern's work there at the site. But there's also going to be a faculty supervisor or university supervisor who will also likely be conducting group supervision at the same time. And so I think it's really important as professionals that the site supervisor and the university supervisor are coordinating and monitoring, because we all see the interns in different contexts and can see different pieces of information to put together a more comprehensive picture of the trainee's strengths and areas for improvement. So some of the supervisee responsibilities, and these are going to depend again on the context of the supervision and on the contract that the two of you work out, but the supervisee's responsibilities are to know the general purpose of supervision, to recognize that different supervisors will attempt to achieve the purpose of supervision in a variety of different ways. And it's been my experience that this can be a source of frustration for some supervisees, but at the same time, it's also a gift that as they discuss in group supervision with their peers, the techniques that one supervisor uses or the focus that one supervisor has versus the other, and learning about all the different ways that supervision and training can be completed. And one's not better or worse than the other, they're just different. And this helps the interns with their tolerance for this ambiguity that doing therapy, doing supervision is not a cookbook approach where you do this and this and this and this. And I think that helps their cognitive complexity to consider all of these different aspects and different ways that the training can occur. Also, the supervisee has the responsibility to accept that there is going to be a certain level of anxiety associated with the supervision process. This is a parallel with counseling and therapy, that there does need to be a certain amount of challenge, amount of anxiety that goes with that challenge in order for the supervisee to grow. The supervisee also is responsible for asking how and when the evaluation will occur so that they know what to expect. They can clarify any questions about the supervision contract, and again, we'll talk about contracts a little later. And supervisees do have a responsibility to strive to be as honest as possible during supervision. Now, this doesn't mean that they have to completely self-disclose and be sharing all these intimate secrets or details of their life. However, they do need to strive to be as honest as possible about a self-evaluation and some of their buttons or their roadblocks, again, as it's impacting the client, as it's impacting their work. They also have the responsibility to ask for what they need. In fact, this is a great question for supervisees within the supervision process, especially whether it's the halfway point, the midterm eval, the final eval, is what do you need from me? Or what am I leaving out? What is working well? And making sure that that supervisee is taking ownership of the supervision process and of the time and how it's used. Also, the supervisee does need to spend time preparing before meeting with the supervisor. I like my supervisees to come in with specific questions, with specific cases, to show that they are using the time for their maximum benefit. Other responsibilities include obtaining and enhancing ethical clinical skills and knowledge. This is, I think, hopefully pretty obvious that we want our supervisees to be practicing ethically and also utilizing appropriate clinical skills. Practicing within the bounds of competence and knowing where those boundaries are. Demonstrating cultural sensitivity and competence across different cultures. And supervisees also have the responsibility to complete their work products, whether this is documentation, treatment plan reviews, assessments. That is their responsibility. And dealing with challenges or consequences of not having a work product as well. And the ability to accurately self-assess. And hopefully this self-assessment is a mutual process, but with many different data points for that assessment, but to know their strengths and what areas to focus on as they grow.